We're going to do Resuscitation Module number 3. This is by far one of my very favorite lectures with regards to resuscitation. I think there's some great points in here that you can take home, and it can really help you when you're evaluating a patient with severe respiratory distress. We're going to be talking about this just in general with approaching patients with moderate to severe respiratory distress as they come into the emergency department. Doctor, come to Resus 1. When you come in, you see a 40-year-old male sitting on the edge of the cart, working very hard to breathe. Respiratory rate 35 to 40. He's dripping sweat. He's awake, but he's not speaking. He's just really focused on his breathing. The tech is trying to get him to lay back, but he will not lay back. What do? Well, just like always, you assess your ABCs, looking for red, yellow, or green lights, meaning that you have to stop and address the emergent threat in the red. Yellow would tell you it's okay for now, but potentially threatened and needs to be readdressed promptly, and green means no threat. Airway. Well, this guy's got no stridor, his airway's patent, he's alert, and you can actually get him to talk. He'll say his name. Rule of thumb. With moderate to severe respiratory distress, airway really can get no better than a yellow designation. Breathing. We're going to separate this again into oxygenation and ventilation, just like always. Okay, as far as oxygenation goes, he's frantic, sitting bolt upright at the side of the bed. He's maximizing his respiratory effort. He's working very hard to breathe. In the red light, yellow light, green light scale, this guy might be an orange. How about ventilation? Well, he's wide awake, his posture's upright, his respiratory rate is 40, his heart rate's well above 100. His ventilation appears to be uncompromised. Is this a green? Well, the question is, how long can you keep this up? It's predictable that anybody in respiratory distress can go from oxygenation to ventilation failure. If you don't do anything about it, they will predictably move from oxygenation failure to ventilatory failure. You just can't keep fighting like that forever. So as far as ventilation goes, oxygenation failure will predictably lead to ventilatory failure if left unchecked. So yellow is really going to be the best assignment you can give a patient in severe respiratory distress. All right, this is the algorithmic approach to moderate to severe respiratory distress. So using the example of the guy who came into Resus at the beginning of this presentation, we're going to ask ourselves 3 magic questions. You need to commit these to memory. This saves you all the time. It really helps to keep you ahead of the game. So remember the 3 magic questions. The first magic question. Do I need to intubate right now? Intubation is not benign. This guy might have eaten a Big Mac and that might be in his airway immediately. He could have tiny little cords behind a huge tongue, making it very difficult to get the tube in. The laryngoscope trauma might obliterate the airway with blood, or the laryngoscope light could go out. Maybe you'd be unable to bag. You never know how it's going to go. So you got to assess the risk benefits. RSI, intubation, and positive pressure ventilation are not benign. But progression to respiratory or cardiac decompensation failure or arrest is unacceptable. So you got to decide when you need to go, when you need to do it. For the cowboys, you're going to need to know that it's worth the risks before you proceed. These are the people who walk in every room when someone's at a respiratory rate under, over 22 and they're thinking about intubating them. On the other hand, there's people who wait forever to intubate somebody. Don't wait until they deteriorate to an irrevocable situation. This is a big mistake. Sometimes waiting too long actually puts the nail in their coffin. Remember the absolute indications for intubation: failure to oxygenate, failure to ventilate, failure to protect the airway. Memorize them. This patient really has no absolute indication for intubation at this time. Let's move on to magic question number 2. Is the respiratory distress rapidly reversible? Otherwise stated, is there potential for resolution of the respiratory distress without intubation? There are really not that many causes of respiratory distress that are rapidly reversible. Here are some. In fact, I think these are all of them. Hypoxia, which can be treated with supplemental oxygen. Bronchospasm, which can be treated with bronchodilators, among other things. Hypertensive pulmonary edema, which can be treated by decreasing the MAP and giving the patient pulmonary vasodilators, a pneumothorax, which would be treated with tube thoracostomy, and an allergic reaction, which could be treated with epi, Benadryl, etc. Fact: there are very few causes of severe respiratory distress that in fact are rapidly reversible. Make sure you memorize them. The guy I set up in the beginning is somebody who turns out to be hypertensive pulmonary edema. So now we move on to question number 3. We've got a guy that didn't absolutely need to be intubated. We know that we have a disease process that is potentially reversible. Now what do we have to ask ourselves? We have to ask ourselves, can he run? This is a euphemism and I think it works great, but what it actually states is, do you have reason to believe that you can reverse the process faster than the patient will decompensate? Are they going to tire out and arrest before you can reverse the process? To me, it helps me to consider the possibility and just look at him and think, can this guy run? Do I believe this guy could run the marathon that's necessary to reverse the cause? When you're actually deciding if they can run, there's a lot of components you have to consider. What does their airway look like? What's the chest wall musculature look like? How big is that chest wall? Can that diaphragm go up and down frequently? Is it obstructed? How are they sitting? Do they have good posture? How old are they? Are they 90? He's probably not going to be able to run. What's the BMI? BMI of 40? That's no runner. Does he have a strong heart? Does he have good lungs? What's his baseline exercise tolerance? To me, if you just look at the patient and think, can he run? My brain rapidly assesses all those things when I'm considering whether a person really would be able to run. Next thing you have to do once you decide they can run is decide how long they can run. You need to set some time limits for yourself. You don't want to just say, okay, it's reversible. Okay, I think he can run. Let's go, and just keep trying to treat him forever, right? You want to get some sense of how long you're going to give that a try. How long will you wait before you intubate? Here's some examples. Let's set some time limits. What if you have a patient with a 20-year-old who's otherwise healthy with asthma, who comes in with an asthma exacerbation? How long would you treat him before you would intubate him? How about a patient who's 40 years old, hypertensive, with hypertensive pulmonary edema, like this guy? How long are you going to let it ride if he doesn't get any better before you intubate? How about a 60-year-old known coronary artery disease with moderate to severe CHF with a moderate blood pressure? How about an 80-year-old with bilateral pneumonia and effusions? Let's think of some numbers. I'm going to give you some numbers here, but these aren't really meant as hard and fast. This is just to give you some sense and get you thinking. So if you have a 20-year-old otherwise healthy asthmatic who while you're treating him has no obvious deterioration, you probably give him at least 30 minutes of treatment before you commit him to intubation, right? Seems about right. Depends on the patient. How about the 40-year-old hypertensive patient with hypertensive pulmonary edema? If he doesn't have any obvious deterioration, you might give him 20 minutes to try to reverse him before you start thinking about intubating him again, as long as he doesn't get worse. What about the 60-year-old with known CAD with moderate to severe CHF and a blood pressure that's modest? This guy probably has a crappy EF. He already has coronary artery disease. You don't want to intubate people that don't need to be intubated. But I wouldn't give this guy a long time to treat him. I'd give it a shot. I'd give him 10 minutes, see how it went. And if he didn't get any better, you'd probably intubate him. All right, now let's think about that 80-year-old with bilateral pneumonia and effusions. Why wait? Is this a reversible cause? Is this a reversible cause? If an 80-year-old woman is in severe respiratory distress and you put them on oxygen at an adequate amount and they don't reverse immediately, you go. You absolutely go. The only reversible cause she could possibly have is hypoxia, but this is really unlikely. The disease process is not going to resolve quickly. All right. So once you've decided to let them run, you want to monitor their response to treatment very carefully, and there's a lot of ways you can do that. Trends can really help you. The clinical signs and symptoms are great. Ask the guy, how you feeling? Are you better? Are you worse? Are you the same? It's wonderful. They know. They know their body. They know their body better than you do, and they feel the changes before you see them. Respiratory rate is something to watch. Oxygen saturation is helpful. The posture, as we said before, is something you really want to consider. If you want more hard evidence, you might do an ABG or VBG to see what the CO2 is, see what the lactic acid is. If the lactic acid is climbing, they're probably doing too much work of breathing and they're probably going to poop out quick. The heart rate and rhythm matters. They better be staying above 100 if they're still working to breathe. And the rhythm, they should be sinus. If they have a dysrhythmia, that's probably compromising the situation, and that's likely to make you intubate them sooner. An EKG with no evidence of ischemia and a chest x-ray that doesn't show you any surprises would be helpful to help you determine how long you're going to let them run. All right. Be careful out there. You guys are getting better all the time. You're ready for many patients already. Keep going to module number 4.